بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we'll start a new series of imaging of a difficult area, which is the anorectal area. And actually, the anatomy and pathology are also uh, complicated by many facts that I will try to explain as simple as I can, and I will show many of illustrative cases so that the any of you can understand what we are going to talk about. Then we have, or I have separated this series of lectures into two parts. The part uh, is concerned with rectal imaging, and this will be also subdivided into two other sectors. Then we'll describe the anal and the perianal pathology, which will be, I hope, presented in two other sectors. Then now in the first part of the rectal pathology, would like to give an overview about the colorectal cancer. Then we'll show the imaging modalities and the imaging techniques, and also we'll explain the imaging anatomy, which is very important. Then we'll present the staging of rectal cancer, including the T and M stage and the staging after chemo radiation. Then we'll evaluate the cancer after preoperative chemotherapy or radiotherapy or both. Then we'll have an idea about the surgical procedures now applicable for the rectal cancer. Then we'll show the normal post-operative appearance after surgery. Then we'll present the post-operative complications, which are a lot, including the tumor recurrence. Then these are the surgical procedures: the abdominoperineal resection, which is an old procedure now replaced by the anterior resection, either high or low. I will mention the indications. Then the Hartmann procedure. Then we'll show the normal postoperative changes. And here the postoperative complications, including wound infection and dehiscence, anastomotic stenosis and leak, intraperitoneal abscesses, fistulae, colitis, incisional hernia, small bowel obstruction, and local tumor recurrence. Then these are the expected topics to be handled in the other sections, including the rectal inflammatory lesions, other rectal neoplasms, and anal anatomy and pathology. Then you remember that the colorectal carcinoma is the most common GIT cancer and the second diagnosed malignancy in adults, maybe after bronchogenic carcinoma. Then surgical resection may be curative, although the 5-year survival rate is in the range of 45%. The mean age of diagnosis is between 60 and 80 years, and there is a slight male predilection for rectal carcinoma. There are a long list of risk factors that can predispose for the development of rectal colorectal cancer, including the low fiber diet, the high fat and animal protein diet, obesity, asbestos workers, colonic adenoma, familial bullosis, Budd-Sugar syndrome, history of colorectal cancer in the family, inflammatory bowel disease, and other factors. Then the clinical presentation of the colorectal carcinoma may include abnormalities in the bowel habit, iron deficiency anemia due to rectal bleeding, bowel obstruction, intussusception, and maybe heavy bleeding, and also metastatic disease. Hereditary syndromes are recognized as seen in 6% of colorectal cancer, like the adenomatous familial bullosis, the familial bullosis of the colon, Gardner syndrome, Turkat syndrome, Budd-Sugar, and the hereditary non-bullosis colon cancer syndrome. The frequency of carcinoma in the colon, the rectosigmoid is most commonly affected, 55%, then the cecum and the ascending colon, then the transverse and the descending colon. The imaging findings in general include a filling defect, which may be exophytic or sessile, a circumferential structure, which is famous for the apple core sign, as you can see here, and by fistulous communication to the bladder or vagina or other bowel loops. Then barium has a low sensitivity for masses which are less than 1 centimeter, and polyps that are more than 1 centimeter, there is a detection rate in the range of 50%. The masses typically appear as the apple core structure, and the fistulae, as I have mentioned, long stenotic segment is very rare, but may be seen with the serous adenomatous serous adenocarcinoma. The CT findings, as you know, that the CT is usually used for staging of the colorectal cancer, any part of the colon except for the rectum, where MRI is much more better for evaluation. The accuracy of CT is in the range of 60%, and CT colonography may be a helpful technique instead of colonoscopy, especially in screening. And most of the lesions are of soft tissue density with luminal narrowing or polypoid mass projecting into the lumen. Calcification are seen in the mucinous adenocarcinoma. Then the imaging modalities for evaluation of the rectal cancer include ultrasonography, which may be transabdominal, endorectal, or transvaginal, CT, MRI, and the PET scan. CT actually has a limited capability in staging of rectal carcinoma because of its relative low resolution. And in this case, you can see that there is circumferential mural thickening of the rectum with a stranding of the perirectal fat, as well as minute mesorectal lymph nodes. An MRI is according to the literature, is the best way for diagnosis and the staging of colorectal cancer. There are certain points other than the pulse sequences and the voxel size, as well as the number of nixes and so on, and the matrix, but there should be adequate coverage of the site of the tumor, including 5 centimeter above the top of the tumor. The scan should be perpendicular to the rectal wall, as I will explain. And in cases of low rectal cancer, the scans are parallel to the anal canal. Then you may give Buscopan or spasmolytic agent to decrease the intestinal motion. Then you may use saturation bands to mask the signal from the aorta and the anterior abdominal structures. Also, you should firmly place the coil and secure abdominal compression, and this will help to inhibit the respiratory motions and will increase the scan quality. Then we need to obtain high resolution T2 weighted images in the sagittal and coronal plane, while the axial images are obtained in an orthogonal plane, and this plane should be perpendicular to the axis of the tumor. And this requires a very good quality sagittal and coronal images, especially the sagittal, in order to have this orthogonal plane. And coronal images are obtained parallel to the anal canal, and we may introduce rectal gel to distend the rectal lumen and to facilitate evaluation of the tumor. And one of the helpful techniques on MRI is the use of diffusion weighted images, especially for detection of small mesorectal lymph nodes. Also, direct to coronal high resolution T2 weighted images is needed to assess the anal sphincter. Then these are the parameters for the high resolution scans, and you can see the difference between the conventional T2 weighted image and the high resolution T2 weighted image. And in high resolution image, you can see the layers of the rectum, including the mucosa and the submucosa, which is of bright signal, and the muscularis propria, which is of low signal. Then you can see the mesorectal fat, and you can also identify the mesorectal fascia. Then this is the difference between a scan before antispasmodic and the scan after antispasmodic. And here you see, because of the intestinal motion, and you got haziness of the tumor, but here you can see that the tumor is more better delineated. Then to use the rectal gel, or the literature prefer to use this for mid and high rectal tumors, not for low rectal tumors. I will explain the causes. Then you need about 60 to 100 milliliter of warm ultrasound gel, and this gel is the volume of the gel is proportional to the site of the tumor. In the mid-rectal tumors, we use a small amount. In the high rectal tumors, we use a larger amount. And gel will delineate the site of the tumor attachment to the rectal wall, which will help in aligning the orthogonal plane. And this is before gel administration, and this is after gel. Then you can see the site of attachment of the tumor to the rectal wall, and you go perpendicular to this site in order to have the orthogonal planes. Then the gel is not used for lower rectal cancer because the stension of the rectum by the gel in this area may obliterate the small perirectal fat, and this will also may obscure the mesorectal lymph nodes. The potential limitations for gel in general, that rectal distension may change the distance between the tumor and the mesorectal fascia, which is an important predicting factor for tumor management. Then motion artifacts may be increased due to the sphincteric contractions. Then we go for this anatomy, which is simple but very important. In the axial and the coronal, in the axial images in particular, you see the layers of the colon. Number one, this layer, which is of high signal intensity in the T2 weighted image, is the mucosa and submucosa. Then the outer layer represents the muscularis propria. It is of low signal intensity. Then you got a very thin, low signal intensity surrounding the rectum and the fat around the rectum, and this is known as the mesorectal fascia. This mesorectal fascia contains some of the lymph nodes and lymphatic vessels as well. The extension of the tumor into the mesorectal fascia is a major predictor for the feasibility of surgery and also the outcome of this surgical or treatment management. And then once more, this is the normal appearance of the rectum. The high T2 signal represents the mucosa and submucosa. The low signal represents the muscularis propria, and this is the mesorectal fascia, and this is the fat around the rectum. Then what is the role of imaging in patients with rectal carcinoma? Number one is accurate preoperative staging of the tumor and the lymph nodes. Then this is a very important issue is to detect the depth of tumor invasion outside the muscularis propria, which will affect the stage of the tumor. Then you detect the relationship between the tumor and the potential circumferential resection margin. In the literature, you will meet this abbreviation very frequently. And by circumferential resection margin, we mean that the mesorectal fascia and its content. This is known as the circumferential resection margin, and you can use the mesorectal fascia instead of this. Then you assess for the possibility of distant metastasis. And this is a tumor of the rectum that has extended beyond the rectal wall. But this image is just to show the mesorectal fascia and to show that there is no mesorectal lymph nodes around the tumor. Then the studies show that high resolution MRI is a reproducible technique with high accuracy for predicting a negative circumferential resection margin, meaning that the tumor has not invaded the mesorectal fascia. The relationship between the tumor and the circumferential resection, meaning that the distance from the tumor to the mesorectal fascia. Then the tumor invasion outside the muscularis propria, as we can see, the muscularis propria is of low signal. Then in this particular area, the tumor has disrupted this layer. Then circumferential resection margin is the mesorectal fascia. The mesorectal fascia is made of the visceral layer of the endopelvic fascia. It surrounds the rectum, the mesorectal fat, lymph nodes, and the lymphatic vessels. In a distance more than 1 millimeter between the tumor and the mesorectal fascia correlates with the decreased local recurrence. Then if the tumor is less than 1 millimeter, the tumor, let us say that the tumor is here, and this is the distance between the mesorectal fascia, and the distance is less than 1 millimeter, and this indicates the possibility of more recurrence compared to the tumors that are away from the mesorectal fascia. A distance of 1 millimeter or less on MRI is considered an indicative of circumferential resection margin involvement. That's to say that if you see that the tumor or the lymph node or the vessel has a distance between it and the mesorectal fascia less than 1 millimeter, consider it involved. And the involvement of the mesorectal fascia is an indication of more probability of local tumor recurrence. Then this distance, 1 millimeter from the tumor margin, from a tumor deposit in the mesorectum, from a tumor thrombus within a vessel, from a malignant node. Any of these that has became intimately related to the mesorectal fascia, then this is an unfavorable sign. Then here you see an extensive tumor in the rectum with stranding of the fat. I will explain the issue of stranding, of fat stranding, but in this section, and you can see multiple lymph nodes, mesorectal lymph nodes, and you see a tumor invading the mesorectal fascia. Then if the tumor has invaded the mesorectal fascia, then you consider a T3 tumor, as I will explain. This is how to measure the distance from the tumor to the mesorectal fascia. In this particular case, you do not need to measure the distance because the mesorectal fascia is already involved. Then another abbreviation you will meet in the literature is known as TME, and this means the total mesorectal excision, which means that there is en bloc resection of the primary tumor, the mesorectum, with the section along the mesorectal fascia. Then in order to reach an accurate staging, then we should have 3 millimeter axial images obtained perpendicular to the tumor plane. This technique will allow in many cases to differentiate between T3 and T2 rectal tumors. The depth of invasion outside the muscularis propria should be assessed very accurately. Total mesorectal excision has resulted in dramatic decrease in the local recurrence rate from 40% to about 10%. A tumor or malignant node within 1 millimeter from the mesorectal fascia is an important factor for recurrence. Reliable preoperative imaging is vital for surgical planning. And sometimes they combine preoperative radiation with the total mesorectal excision, and this has helped in a reduction of the recurrence rate from 8% to about 2%. Then the peritoneum will cover the dome of the urinary bladder and extend along the anterior wall of the rectum. An invasion of the peritoneum is considered T4A disease. And actually, we do not see the peritoneum in this particular area, but we can assume that if you see that the tumor is invading the area above, immediately above the urinary bladder, then you consider involvement of the peritoneal reflections. But in many cases, you can see the involved peritoneum because it has been thickened so that you can elicit in the imaging. And this is the peritoneal reflection in a normal condition. And you see it is just superior to the urinary bladder in the sagittal image, which is, according to the literature, the most common or the most preferable plane for assessment of the peritoneal reflections. Then this is just a way or a descriptive way for how to deal with rectal cancer from the point of view of the surgeon. They include or they insist for digital rectal examination plus abdominopelvic CT. Then if palpable tumor is fixed or the mesorectal fascia is involved, then you should have preoperative radiotherapy or combined with chemotherapy. If the palpable tumor is mobile or the mesorectal fascia is clear on CT, then go direct for surgery. If palpable tumor tethered means fixed, or mesorectal fascia potentially involved, looks to be involved, then you go to MRI. If the mesorectal fascia is clear, go to surgery. If the mesorectal fascia is involved, then go to preoperative chemoradiation. And these are the rectal cancer staging. Stage 1 involving the mucosa and the submucosa. Stage 2 involvement of the inner layers of the muscularis propria. Stage 3 is the start of extension outside the muscularis propria, and this is divided into 4 stages. Stage 3A, tumor extends for less than 1 millimeter beyond the muscularis propria. B, tumor extends from 1 to 5 millimeter beyond the muscularis propria. C, the tumor extends from 5 to 15 millimeter. D, the tumor extends more than 15 millimeter beyond the muscularis propria. Then T4A, invasion of the peritoneum. T4B, invasion of other viscera like the uterus, the bladder, the seminal vesicle, and the prostate. Then on T2 weighted image, you can diagnose T1 and T2 tumors that are confined to the rectal lumen with preservation of the thickness and the integrity of the muscularis propria. Then starting from T3 tumors that extend beyond the muscularis propria into the mesorectal fat, then we have to be careful in judgment of such involvement. Then more than 5 millimeter invasion outside the muscularis propria will lead to drop of the survival rate from 85 to 55%. Then less than 5 millimeter invasion means that you are dealing with early T3 stage, and sometimes T3 stage may be mistaken with T2 tumor, especially as I will show to you if you got some strands in the mesorectal fat. Then here, this is T1 cancer, and the outer layer of the colon is intact, and the tumor is totally within the confinement of the colon. And this is T2 cancer, where in the muscularis propria, the low signal line appears intact at the base of the tumor. And this is also a T2 rectal cancer, where you can see the tumor and you see the integrity of the anterior aspect of the rectum, and also it's very clear in the T2 weighted image. Then, and this is another example. I'm trying to give many examples that you are got familiar with this particular area of anatomy and pathology. Then you see this mass, and you got the intactness of the muscularis propria, which is also seen. The axial images are very good for the evaluation of the tumor margin. Another appearance of T2 cancer, and you see that the muscularis propria is intact, and the tumor is totally confined to the rectal lumen. Then you got here, and you see a tumor, and this tumor is associated with a stranding of the fat. A stranding of the fat means one of two. Either this is a tumor infiltration, or this is a desmoblastic reaction. Desmoblastic reaction means that these are fibrous bands and they are not tumor. If these are fibrous bands, then you consider T2. If these are tumor invasions, then you consider T3. Then this is the situation where you cannot discriminate between T2 and the early T3 rectal tumor. And according to the literature, they said that if you see a lesion like this and you got a stranding of the fat, and these strands are linear, not nodular, and not associated with lymphadenopathy, then you consider it desmoplastic reaction and you consider the tumor stage as stage 2. Then, if you see there is a tumor with a stranding of the perirectal fat, and these strands are thick and they may be nodular in appearance, then you consider this as stage 3. And according to the literature, they said also that diffusion weighted images can help to assess invasion of the muscularis propria. In the axial T2, you see the low signal rim, and you see that this area is discontinuous, looks like so. But in the diffusion weighted image, and you can see the disruption of the muscularis propria, in the diffusion weighted image, and also you can detect multiple lymph nodes which show diffusion restriction, and this is in the coronal plane. Another T3 tumor where you got thickness of the left lateral rectal wall and fatty strands which are nodular, and this is stage T3. Then in this tumor, you got a disruption of the muscularis propria, and you got a small mesorectal lymph node. These lymph nodes are very important in the staging of the tumor. And here is another example of stage 3. You got the total disruption of the left lateral rectal wall, and you see minute structures which may represent the lymphatics, and this is the intact mesorectal fascia. Another example of a stage 3 tumor, and you got a significant lesion that has invaded the mesorectal fat, and there is also a lymph node adjacent to the tumor. And in this case, you want to measure the distance between the tumor and the mesorectal fascia, which is helpful, as I mentioned, as a predictor for tumor recurrence. Then here is an advanced T3 rectal cancer that has invaded the mesorectal fascia associated with lymph node in the mesorectal fat. This tumor is more liable for recurrence than the tumors that are sit away from the mesorectal fascia. Then stage T4B means that there is invasion of the adjacent anatomic structures like the seminal vesicle and the prostate in male, the cervix and the vagina in female. Then you see here that there is total obliteration of the mesorectal fat, many of the mesorectal lymph nodes, and there is obliteration of the high signal within the seminal vesicle in this particular area, denoting invasion. And in this case, you got invasion of the perirectal fat as well as the peritoneum. Why here you see that the peritoneum? Because it is thickened, being infiltrated by the tumor, and you know that invasion of the peritoneum means that you are dealing with T4A. Then another appearance of invasion of the peritoneum, you got these nodularities which are high away from the level of the urinary bladder, denoting peritoneal metastasis, and you also see the presacral lymphadenopathy. Then stage T4B means that the tumor has invaded the peritoneal structures as well as the adjacent organs, as you will see. Then here you see the mesorectal fascia, and there is significant perirectal invasion. Then in this axial image, you see that the tumor is invading one of the small bowel loops, and this indicates that you are dealing with stage T4B, and this may be clearly seen in the sagittal image. Also, you can see presacral lymphadenopathy. Then here, the tumor is invading the prostate, and this means that you are dealing with stage T4B. Then we came to the lymph nodes. The lymph nodes that are present within the mesorectal fascia are resected in this total mesorectal excision. Then the relation of malignant node to the mesorectal fascia should be carefully assessed, and there should be a distance more than 1 millimeter from these nodes between the nodes and the mesorectal fascia. Then nodes outside the mesorectal fascia are not routinely resected unless they are definitely malignant. And malignant external iliac and superficial inguinal nodes may indicate metastasis and M1 disease. The size threshold for distinguishing between malignant and non-malignant nodes in this particular area is 5 millimeter. And if you use this threshold, you will got the sensitivity about 70% and the specificity about 80%. But about 40% of nodal metastases of rectal cancer occur in nodes less than 5 millimeter. Then you should have some of the criteria to help you, like the irregularity or speculated margin of the lymph node and the heterogeneous signal intensity. Then you have three major parameters for nodal suspicion to be malignant. Number one, irregularity of the margin. Number two, heterogeneity of the signal. Number three, rounded shape. You know that the normal node is more or less kidney shape. Then the short axis means that you measure the narrow distance of the lymph node margins. If the short axis is less than 5 millimeter, then you in order to judge that this is suspicious for malignancy, you need the three criteria: irregular border, heterogeneous margin, and rounded. If the short axis is from 5 to 9, then you need only two malignant criteria, like this and this, or this and this. Then if the short axis is more than 9 millimeter, you may consider it malignant. The nodal staging, if there is no node, this is N0. N1, there are 1 to 3 suspicious lymph nodes. N2, more than 4 suspicious lymph nodes. Then you see here in the presacral area, multiple suspicious lymph nodes. And also in this patient, you see a tumor that has disrupted the muscularis propria and is associated with this lymph node. One of the landmarks here is that this asterisk points to the high signal intensity of the tumor and also the lymph node, indicating the presence of mucin, and this is suggestive of mucinous adenocarcinoma. Here is what's known as extra mesorectal lymph node. This is the mesorectal fascia which is involved by the tumor, and there is a lymph node outside the mesorectal fascia. Then this is the node by diffusion weighted image. And these lymph nodes are usually treated before surgery by radiation or chemotherapy. Another lymph node, and you see that this is a relatively big lymph node which is outside the confinement of the mesorectal fascia, and this is the tumor itself. Then, as I have mentioned, that if you have an advanced stage of the tumor with invasion of the mesorectal fascia or extra mesorectal lymph nodes, you may need preoperative chemo therapy or radiation to downstage the tumor, and then you can operate. And after preoperative chemo and radiotherapy, we want to evaluate the tumor and also to evaluate the lymph nodes. Then it's very important to see the relation between the tumor and the anal sphincter as well as the pelvic side walls, is to assess the circumferential resection margin, which is the mesorectal fascia, and to detect the smallest distance between the tumor and the fascia. Then you look for extra mesorectal invasion, which can disappear after treatment and replaced by fibrosis. Then, concerning the nodes, you assess the remaining suspicious lymph nodes and the exact location. According to the literature, many of the irradiated nodes disappear, but most of the remaining nodes are sterilized from the tumor cells. After therapy, the short axis nodal size is the more reliable than other, the border and the heterogeneity. Then reliable indicators of negative nodes before surgery: number one, absence of lymph nodes on the fusion weighted images, decrease in the size by about 70% of the lymph node, and the nodal size less than 2.5 millimeter in the short axis. And this is an example of a patient treated rectal cancer with metastatic mesorectal lymph node, and this is after therapy, and you got regression in the tumor size, which is now of low signal intensity, suggestive of fibrosis, and also regression in the size of the lymph node, which also showed decrease in the signal, suggestive of fibrosis. And this is another example, an extra mesorectal lymph node and the tumor. Then after therapy, you got regression of the size of the node as well as regression of the tumor itself. Then this is provided grading to correlate with the possible survival outcome of the patient. This is also present on the internet, and they said that grade 1 means complete radiologic response to chemoradiation with no evidence of the treated tumor. Grade 2, good response with dense fibrosis more than 75%. Grade 3, moderate response with more than 50% fibrosis or mucin. Grade 4, a slight response with little areas of fibrosis and most large area of tumor tissue. Grade 5, no response. And here, this is a rectal tumor that is evaluated after chemotherapy. You see the regression of the tumor size. And this is another example of a rectal tumor involving the right side of the rectal wall after long course of chemoradiotherapy. You show there is a significant regression in the tumor size with is remaining a small area of diffusion restriction, which is suggestive of residual tumor. And this is an example of a rectal cancer. This is before therapy, this is after therapy, and this is after surgery. And you got almost normal findings. And this is another tumor that has been treated by chemo irradiation, and you got let us say moderate response to the treatment, and this is classified as a grade 3 with moderate response to the treatment. And here you see what's known as the tumicidal effect of the chemotherapy and irradiation. You got this circumference of tumor infiltration of the rectal wall. Then on follow-up, you got reduction and another follow-up 22 weeks post chemo irradiation, and you see the considerable regression of the tumor. This follow-up was done 4 weeks, and this follow-up was done 22 weeks. Then in this example, you see a big tumor that has extended into the mesorectal fascia and the presacral space with invasion of the possible invasion of the mesorectal fascia, and this is diffusion weighted image showing diffusion restriction. After therapy, you got regression of the tumor and no diffusion restriction. Means that the remaining tissue here represents fibrosis rather than a tumor residue. Then what are the surgical procedures that are available for management of rectal cancer? We have three. Number one, which is an old surgical procedure known as abdominoperineal resection. And you resect the area shaded in gray, including the anal sphincter, and you put the patient on a permanent colostomy. Then this was indicated for low rectal cancers, primary or recurrent, less than 8 centimeter above the pectinate line, which is the separation line between the anal canal and the lower part of the rectum. I will explain this in details in the anal imaging. Then anal malignancies and anorectal complications of inflammatory bowel disease like the Crohn's and the ulcerative colitis. Actually, after removing this particular area, the bladder, seminal vesicles, and some bowel loops will move posteriorly into the precoccygeal location. And this technique is now less frequently performed due to the development of sphincter sparing low anterior resection, I will show, the circular stapling techniques, and improvement in the adjuvant cancer therapy, including chemo and radiotherapy before surgery. Then in this operation, you got permanent colostomy, and the operative field will frequently show this presacral soft tissue mass. And this presacral soft tissue mass representing post-operative fibrosis and granulation tissue, and is usually in the range of size between 3 and 5 centimeters. This lesion will decrease in size and shape on follow-up studies. It may remain for up to 2 years or even indefinitely for many years. A presacral mass is considered normal post-operative changes in patients with lack of growth over 1 to 2 years, clinical stability, and normal carcinoembryonic antigen levels. Then, in the preoperative follow-up for abdominoperineal resection, frequently you see this presacral soft tissue lesion, which represents the post-operative changes, and on PET-CT you do not see any activity within the lesion. After you remove the rectum and the anal canal, the viscera will be displaced posteriorly, and in this case you can see the rectum, and also the urinary bladder will be displaced. Then the second type of surgery is the anterior resection, which may be high or low, and this involves resection of the rectosigmoid without perineal dissection, and there is anastomosis of the descending colon to the proximal part of the rectum, maintaining the anal sphincter function. And this is a very good operation where you do not need to perform colostomy, either temporary or permanent. The indications for anterior resection include sigmoid diverticular disease, rectal carcinoma more than 8 centimeters above the pectineal line. The low anterior resection is commonly accompanied by the low anterior resection, which leaves only the distal part of the anal canal and anal sphincter, total mesorectal resection, resection of the entire mesentery of the mid and lower rectum, resection of the pelvic fascia containing lymphatic drainage of the rectal tumor. Then the imaging following anterior resection, after you remove this part of the colon and you got midline collection of fluid or a small soft tissue mass in the presacral space representing postoperative granulation tissue. Also, you see the sutures, which are typically radio opaque in the CT scan. Then you may elicit some wall thickness from postoperative edema, and at the site of anastomosis, the rectum is displaced up 2 centimeters anteriorly from the sacrum, and you got large presacral space, and you may got extraperitoneal air and fluid collection around the iliac vessels. Then when to suspect that there is an ostomotic leak or recurrence of the tumor, if you detect marked anterior displacement of the rectum for more than 3 to 5 centimeters or increase in the amount of soft tissues or fluid. Then the third type of operation is known as the Hartmann procedure, and there is surgical resection of the rectosigmoid with closure of the rectal stump and the temporary colostomy. And you remove this area shaded in gray, and the rectum will be sutured, and there should be a colostomy, and this operation is indicated for bowel cancer and diverticular disease. Then, and the last issue in this lecture is to evaluate the post-operative normal appearance and the complications. It's worth to mention that CT is the most reliable imaging modalities for post-operative cancer evaluation. Then you should have a baseline CT performed 3 months after surgery, and follow up every 6 months thereafter to exclude the tumor recurrence. Also, the multi-detector CT should be performed with injection of contrast material inside the rectum if you suspect an ostomatic leak. And here is the early postoperative changes where you got edema, swelling, and granulation tissue surrounding the rectum, and this is considered an early normal postoperative changes. And here also you see that the sutures are radio opaque in the CT scan. You see a pre-rectal, pre-sacral soft tissue lesion, which are considered normal findings. Then you got the to the complications. When we have the complications, wound dehiscence or infection, anastomotic stenosis, leak, abscesses, fistula, hernia, small bowel obstruction, and local tumor recurrence. Then we start by the wound dehiscence. Wound dehiscence means gapping at the sutures or the site of the incision. And this wound dehiscence occurs in the range of 5 to 8 days following surgery. There are underlying causes including ischemia, infection, diabetes, malnutrition, smoking, obesity, or increased intra-abdominal pressure. Then you should identify this very quickly and treat very quickly because of worsening dehiscence, infection, and the hernia with possible strangulation. And these are early changes in the wound dehiscence, and you got some air loculi as well as fluid density at the suture line. And this is the colostomy because this patient had a Hartmann procedure. Then anastomotic stricture is benign anastomotic stricture not related to cancer recurrence, may be seen in up to 22% of the patients. The incidence of stricture has risen due to the use of stapler devices. And the treatment of anastomotic stricture is indicated to decrease the risk of possibility of developing of cancer over time and to avoid obstruction or obstructive symptoms. This structure was traditionally surgically treated, but now we have so many alternatives. Surgical treatment has been replaced by endoscopic techniques like balloon dilatation or dilatation with this bogies, which are used primarily for esophageal strictures. And there are some drawbacks of these techniques also, including that inaccessible stricture, high stricture recurrence rate in up to 20% of the cases, increased risk of perforation, and failure of improvement with multiple sessions of dilatation. Then a new technique which is known as endoscopic electrocautery incision has been described in the literature as an alternative for management of benign strictures. This technique use the cautery probe to excise the site of the structure, which is followed by dilatation, and you got after dilatation, and this is the final follow-up 4 weeks later on. This is the initial, and this is the final image. Then this is the normal appearance or the normal flow of the gastrografin or barium through the anastomotic site, and this is anastomotic structure, and the dye cannot flow beyond the site of occlusion. And this is another example. You got a big mass anterior to the sacrum of fibrosis that has totally occluded the rectal lumen so that the injected gastrografin cannot pass beyond the site of the occlusion. Then you got anastomotic leak, which is a serious condition and is associated with high morbidity and mortality. It may lead to complications like peritonitis and sepsis. If it is not identified, the mortality rate can be as high up 50% of the case. Anastomotic leak usually seen in the second postoperative week and or in the first two postoperative weeks, especially in the days between 5 and 7. The patient may complain of fever, abdominal pain, tachycardia, guarding, and tenderness, and leak incidence has been reported in around 22% of the cases. There are what's known as occurred leak, which may persist for years without significant symptoms. And leak will result in accumulation of air and the fluid in the pre-sacral space. And if this is seen 6 months after surgery, it is highly suggestive of a leak. Loculated fluid containing air is the most common indicator of anastomotic leak. Then some of the literature considered that disruption of the suture line is an indication of anastomotic leak or a sign of anastomotic leak. But you can see this leak very nicely by injecting contrast material, let us say gastrografin, then you see the leakage from the site of anastomosis. And this patient had anterior resection 3 months before, now presenting by fever and abdominal pain. Then the gastrografin enema showed leakage of contrast material and air in the widened presacral space that has been also clearly seen by CT, and you got air fluid level denoting the anastomotic leak. And this is another example of a patient with fever and tachycardia on the 7th post-operative day after palliative rectosigmoidectomy for metastatic colonic cancer. You see the suture line and you see a small pocket of air adjacent to the colon. After injection of contrast material, you see the site of leak and you see that this pocket of air contains some of the injected contrast material. Another appearance of anastomotic leak, and this is known as the double rectum sign, where you got a lesion which simulates rectum in the presacral space, and anterior to it you can see the original rectum. And here, this is the nozzle for injecting contrast material. This is the rectum, and this is the presacral leak. Actually, the CT scan helped by perirectal contrast injection is very much helpful to detect these anastomotic leaks. Then this is another example, and you got air contrast material and fluids in the retrorectal area. With this is the rectum and this is the site of the leak. And actually, CT is one of the good modalities to guide percutaneous catheter drainage of such leaks. Then fistula is also one of the complications, and you got fistula between the colon and the bladder, and you got fistula between the colon and the ureter, and between the vagina, and so on. Then how to diagnose this? One of the ways is to inject contrast material. This patient underwent restorative proctocolectomy with ileal pouch anal anastomosis. And according to the literature, this type of surgery is liable for this complication in particular. Then the patient is passing a stool from the urethra. Injection of contrast through the urethra goes into the rectum and anal canal. And here you can see the accumulation of fluid and gas in the presacral area. Then abscesses are also a complication of colorectal surgery, and this patient had peritonitis from leakage of colosigmoid anastomosis. And you got fluid in the peritoneum, you got also air in the peritoneum and enhancement of the peritoneal reflections. And then this patient who presented by blood with stools diagnosed to have rectal cancer that was laparoscopically resected. 3 months later, he presented by persistent pain caused by a swollen elastic hard mass in the right lower quadrant at the site of port of the used for endoscopic resection. Then and this CT scan, you got a subcutaneous marginally enhanced lesion, but the PET scan showed severe metabolic activity, and they suspected local tumor recurrence, but after excision, it proved to be an abscess. And it's another example of a presacral abscess. It shows the same criteria of an abscess elsewhere in the body. And this is also an abscess in the right presacral area. You got thick margin enhancement and air fluid level inside the abscess. Then hernia may complicate some of the abdominal surgeries, including this type of surgery, and you got a displacement of the bowel loops inside the hernial sac. The bowel loops may be incarcerated and may show some fluid levels denoting incarceration. But here you can see the bowel loops outlined by orally administered contrast material with no signs of incarceration. The small bowel obstruction is a common post-operative complication and can be seen in about 30% of the cases performing an ileal pouch anal anastomosis. This is also a frequent complication. Typically occurs about 30 days after the procedure, and the explanation is that the bullet ileum will stretch the mesentery and can cause bowel obstruction. Other causes include adhesion, stricture, volvulus, tumor recurrence, and inflammatory process. And this patient has presented by abdominal pain, distension, and vomiting, all the signs of intestinal obstruction after surgery for rectal cancer. And the MRI showed that there is at the transition point between the dilated loops and the normal loops in area of irregular signal intensity, and it shows some faint contrast enhancement, and this is the diffusion weighted image shows some restriction. This is the EDC map showing some restriction of diffusion, and here you got the scan in the upper abdomen showed the markedly dilated bowel loops with multiple air fluid levels. Also here, you see, this is the suture line, and this is tumor recurrence at the anastomotic site that has encroached on the lumen, resulted in proximal intestinal obstruction with dilated bowel loops containing multiple air fluid levels. Finally, we came to the tumor recurrence, and local recurrence can occur in about 70% of cases within 2 years of surgery, and 85% occur within 3 years. Then in 30% of recurrence, the patients are usually asymptomatic. Patients may present by rectal bleeding or a change in the bowel habits. Pain is considered as a serious symptom, which means that there is involvement of other pelvic organs like nerves or bony structures. In about 50% of the cases, you can detect distant metastasis diagnosed with recurrence. And CT is the primary imaging modality for the diagnosis of distant metastases like the lung and liver, and the MRI for local staging of recurrence. Then the main risk factors for local recurrence: number one, lack of preoperative radiation, positive involvement of the mesorectal fascia, extra mesorectal invasion, close proximity of the tumor to the anal verge, perforation of the tumor at surgery, and anastomotic leak. There are different directions for recurrence: anterior, posterior, and lateral. But it is worth to know that most of the local recurrences occur at the anastomotic site. Then anastomotic recurrence can be easily identified clinically and also by endoscopy. Then these are the signs of local recurrence: an increase in the size, early heterogeneous marked contrast enhancement, invasive behavior with asymmetric appearance. In patients with high risk of tumor recurrence, should have annual CT scan of the chest, abdomen, and pelvis for 3 years after the primary therapy, and flexible sigmoidoscopy every 6 months for 5 years if feasible. And no recommendation for routine use of MRI for follow-up. Then recurrent tumor display high signal intensity compared to that of the muscle, while the other tissues may also show high signal intensity like granulation tissue, hematoma, and radiation-induced inflammatory changes. Fibrotic scars may and local tumor recurrence and inflammation all well enhanced with contrast injection. Fibrous tissue may mature over years and become of low signal intensity. Then the diffusion weighted image is one of the helpful techniques to assess for the tumor recurrence. This is what we call an extraluminal or extramural tumor recurrence that is not feasible to be detected by the endoscope. But this is an example of a recurrent lesion in the rectal wall within the confinement of the mesorectal fascia. And this is the tumor in the T2 weighted image, and this is in the T1 post contrast, and you see enhancement of the lesion. Another example of local recurrence, and you see the low signal intensity of the tumor in T2 and the enhancement after injection of contrast material. And this is the false impression of local recurrence. You got a low signal intensity or intermediate signal intensity lesion, and this lesion enhances markedly after injection of contrast. And the PET scan showed significant metabolic activity, but in surgery, they discover only inflammatory changes. And this is also a false impression of recurrence due to this sutural line, this suture, which is clearly seen in the CT, but is not seen, of course, in MRI, and you can suspect that this is a local recurrence. But this is a local recurrence in a true local recurrence. You got a mass in the presacral area, and this mass may represent normal post-operative fibrous tissue after abdominoperineal resection, but if the mass is increasing by time or getting regular, and now the PET scan also is helpful to detect metabolic activity within the mass. This indicates that there is a tumor recurrence. And this is also a nodal recurrence in the pararectal lymph node with significant metabolic activity. And this is another example of local tumor recurrence in the presacral area where you see metabolic activity inside the lesion, and you also detect another metastatic lymph node nearby. And this is an example of local recurrence that has been missed in the MRT2 weighted image, but is seen very clearly in the diffusion weighted image. Then if you combine both images, and you got the exact site of the lesion, which has been confirmed surgically. Actually, the recurrences outside the anastomotic site are easily diagnosed, like involvement of the sacrum by a metastatic deposit, and the involvement of the external iliac vessel by a tumor mass, and the involvement of the sciatic nerve by a lesion which is of intermediate signal in the T2 weighted image and enhances significantly after contrast, and involvement of the obturator internus muscle, and if you are outside the region of anastomotic site, the assessment is easy. And here you can see involvement of the sacral nerve roots. You see, these are the sacral foramina, and this is metastasis to the sacral nerve roots, and at L5 and S1 levels. Then finally, what is the role of the radiologist in this particular subject? Number one is to check the medical records. He should have an idea about the results of digital rectal evaluation, the results of endoscopic examination, and the results of previous treatment like biopsy, surgery, radio, or chemotherapy. Then he should evaluate the tumor borders, and you see mucinous tumors which have poor prognosis, and you see the most invasive border of the tumor. Then identify the tumor location, the site of the tumor in the rectum, circumferential plane of involvement, referred to the clock position, relation to the peritoneal reflection, distance of the tumor from the anorectal junction and the anal verge, which is a very important indicator for the surgery. This is one of the ways to how to measure the distance between the tumor and the anal verge, and you put a line measuring the anal canal separately, then another line from the top of the anal canal to the inferior margin of the tumor. Then you stage the tumor by T and M and nodal stage, and you especially emphasize on the tumor mesorectal fascia distance. Then sphincteric complex, you assess the internal sphincter, the external sphincter, and the levator ani. These are three different ways how to measure the distance of the tumor from the anal verge. Either you put a line for the anal canal separately and another line from this one to the tumor margin, or you just direct measure the distance like this, or you have a curved line to measure the distance. Thank you very much. Alhamdulillahi Rabbil Alameen.